Now, it is the time to talk about the left main and bifurcation disease, a heart of the TCTAP over 25 years. My name is D.Y. Gang from Asan Medical Center. Left main and bifurcation disease are symbol of the complex chronic disease that every operator meets and overcomes. Today, two expert operators will share their struggles on this complex disease, resulting triumphs and failures, and the four principal investigators of the most important randomized trials about left main and bifurcation disease will show their best results and insights. Two masters of the left main and bifurcation PCI, Dr. Antonio Colombo and Dr. Seung-Jung Park, will moderate this special session together.
All right, really thank you for everyone for joining our virtual sessions, highlight session for the main and bifurcation PCI. I am S.A. Park from Korea, and my co-moderator is Antonio Colombo is here. Really, thank you for joining us. And so we have a really distinguished discussion, Dr. An from Korea, Adrian Banning from United Kingdom, Alaide Chieffo from Italy, David Ganchari, and Antonio, would you introduce the first talk, master operator cases, the main and bifurcation?
Okay, so I think we can start. Dr. Duk-Woo Park from Asan Medical Center will start this session with my challenging left main PCI case of the year.
Okay, thank you, Antonio, and thank you, everybody, and I really appreciate participating this left main bifurcation session. So I'm gonna share my challenging the left main PCI. This is a case of this year. Okay, this is my disclosure. Okay, this patient is a 76-year-old male presented with stable angina and the current heavy smoker with a 55 PEG year history. Looking at his background, past medical history, he has hypertension and smoking. There is no diabetic. Looking at ECG was absolutely normal. Chest X-ray is there is no pulmonary edema, and heart size was normal. Looking at the baseline, the echocardiography, ejection fraction 64, and normal LV size and systolic function. So, and looking at the baseline coronary angiogram, and the right coronary artery was totally obstructed, very severe calcification. This looks like a chronic total occlusion. Looking at the left coronary angiogram and the RAO view, and there was a very severe calcification, Ramus branch, Alaide branch, and the Circa branch, and the LA part also we can see very severe calcification. Looking at the spiral view, and this is distal left main, it looks okay, but Alaide ostium, prox Alaide, there was a severe calcification. Ramus branch is a very severe calcification. Circa ostium relatively looks okay. So, and looking at our strategic plan, 76-year male, stable angina, hypertension, smoking, the left main and 3 vascular disease and severe calcification, syntax score 43. We discussed 2 times heart team discussion, and first we recommend the bypass surgery, but the patient was reluctant very strongly. So we finally decided PCI. So if PCI, which strategy? Left main PCI technique, imaging versus angiographic guided, and elective hemodynamic support like IABP or Impella, and how can you do RCA CTO region OMT or PCI. So finally, we decided to PCI. The reason why patient strongly reject bypass surgery, and so we put the wire Alaide, BMW, Ramus branch, Sion blue. Looking at the circle ostium, relatively okay. So we didn't put the the guide wire. The reason why is to reduce the complexity. So we tried the first IBUS Alaide, but the severe calcification, IBUS does not pass. So we then the IBUS Ramus branch. Looking at the Ramus branch, distal Ramus branch, vessel size 2.5, 275, and you can see the proximal Ramus, there is severe calcification. Ramus ostium, we can see the plaque burden is huge. So we decided to the balloon crush technique, and the left main to RI, and then left main to Alaide, and we try to crush technique, and the circle ostium here looks okay. We first 2.5 compliant balloon in Ramus branch. This is immediate after pre-balloon dilation Ramus branch. So, and on the basis of the IVUS finding, we decide to put the Onyx 3.030 in Ramus branch, and then we do left main Alaide balloon crush, and Ramus stands slightly protruded to the left main, and we do a 3.5 NC balloon. So patient the complaint acute chest pain, there was some sudden BP drop and bradycardia. Here is we find the absence of LCX flow, and we do urgent wiring at LCX. At first time, I immediately neglect not putting wire at LCX. Angiographically looks okay to avoid complexity. We just put the wire Ramus branch Alaide, but it's fortunately it was very lucky to pass wire to LCX. So what happened in the LCX, and we evaluated IVUS immediately, looking at the distal LCX, the proxy LCX, LCS ostium. We can see there was iatrogenic, huge, big dissection from the distal LCX to the left main. So, and we do salvage balloon and stenting and LCX. So after balloon dilatation, there is still no referral distal part. We put urgently Onyx 3.538, and then after insertion of the long stent suck distal part, the flow was restored. So, and we checked the IVUS LCX also and Alaide also. We can see the LCX also, there was some severe calcification. Alaide also there was a calcification. So we definitely moved to the bifurcation PCI to the trifurcation PCI. So pre-dilation in Alaide, here we put the long stent 2.75, 35 Alaide, and then LCX ostium, we tried to slightly protruded Onyx 3.5, 26, and then the crush with the left main Alaide balloon crush. And then we finally put the Onyx 3.5, 38 left main to Alaide, and the mid Alaide part, we did very aggressive non-compliant balloon dilation, also left main proxy Alaide high pressure balloon dilation. So this is the immediate post-stenting. So the next step, we do final kissing Alaide Ramus branch first, and then Alaide LCX kissing second. We use the non-compliant balloon Alaide 3.5, Ramus 3.0, LCX 3.5. Finally, we did the triple kissing balloon at distal left main trifurcation using 3.5 Alaide, 3.5 LCX, 3.0 Ramus branch. Looking at the final region, angiographically looks great, and the spider view, very beautiful angiographic result. So, and finally we check it up the IVUS. Over here, Ramus ostium is widely open, LCX ostium was widely open, Alaide ostium was widely open, and the left main is widely often result was perfect. So we decided to right coronary artery is an optimal medical treatment. Patient is well followed during the outpatient clinic. So this is my last slide. Lessons learned from this challenging case of the year. Regardless of initial morphology of distal leg main bifurcation or trifurcation, if possible, put all wire in all branches. For complex distal leg main bifurcation region, imaging-guided PCI is essential for detection of complication and PCI optimization. During leg main bifurcation PCI, unexpected complication can be happen at any time. Don't panic even in unexpected situation. Complex stenting is possible by quickly formulating strategy in your mind. A key wisdom for this challenging case: there is always a way out if you keep your head on straight. Thank you for your attention.
Very nice lessons. We keep the discussion at the end. The next presenter is Thierry Lefevre from France. He will again give another challenging bifurcational case.
It's really a pleasure to be with you at this great session. Unfortunately virtual, but I think it will be really a great discussion. So my challenging bifurcation this year was a very old lady, so 90 years old, very active, up to admission in a hospital, another hospital than Massy, for acute coronary syndrome. It was initially complicated by cardiac failure. On EKG, there was severe ST segment depression in the anterior leads. And then she went in few hours in cardiac shock. The hospital was able to do coronary angiogram, but they thought that this patient was too old and in a too bad situation to do the coronary angiogram. So troponin, the 1 day later, was very high. And by echo, ejection fraction was 30% with anteroseptal and lateral akinesia. If you look at the risk factors, she had the hypertension, dyslipidemia, family history of coronary disease. It was a small woman with chronic anemia, but we don't know what was the cause, and we still don't know. And she was driving his car until recently. I think it's a very important point, despite the fact that she is 90 years old. So she was on catecholamine and diuretics for 10 days, and she recovered progressively, fortunately. She had acute renal failure, but she went back to a good renal function, not too poor. And they decide to do coronary angiogram at day 15 after the initial admission. So this is a coronary angiogram, and you can see the very tight stenosis of the ostium of the left main with a long lesion, with a normal distal runoff without any significant lesion in the Alaide or Circ. This is another view. You can see clearly this very severe lesion at the ostium of the left main with a large Alaide and Circ. This is a cranial view. And the right coronary artery was with a significant lesion, not critical, but very significant. So this patient was admitted in the city of Troyes, and I have good friends in this city, so they decide to call me. What should we do with this patient? So we had a long discussion, and I thought that if we don't do anything to this patient, the risk of death will be very high within the next few months. So I say, okay, send the patient to me, and we'll see what we can do. So it's 180 kilometers from Massy. So as you can see, when she arrived to the hospital, she had a good pressure, even a little bit too good, no pulmonary edema, Hemoglobin was still at 9. Creatinine clearance was not very good, but it's usual in these very old patients. Troponin was back to normal, and BNP was only 1,300. If you look at the EKG, it was nearly normal. So she back to nearly normal. And the echo was not so bad. So now we have to decide about the strategy in this patient. So I think it's very important to take time to discuss with the team. Of course, this patient will not have surgery because she's 90 years old. And it's very nice to reconstruct this lesion to understand where we will find the difficulties in this 100 Medina left main bifurcation lesion. So of course, she's high bleeding risk. We think that in this kind of case, it's very important to have intra-aortic balloon pump on board in order to have a little bit more time to for balloon inflation. We thought that it will be better to start with the right coronary artery first because it was not a complex lesion, but the left main was very complex. And we thought that provisional cyber stenting approach could be the good approach in this kind of case with a 100 bifurcation lesion. We decided to start with a GL in order not to compromise the left main with extra backup guiding catheter because the risk of dissection in this ostial lesion is very high. And we thought that wiring toward the Alaide may be difficult. And maybe we should use rotablator at one time during the procedure. And of course, we have to decide which kind of stent because the Alaide is close to 4 and the SOC is close to 4. So we start with the right. You see it's exactly the same as it was during the coronary angiogram 2 days before. Balloon predilatation with non-compliant balloon, high pressure, stent, and this is a result, which I think is very acceptable, with a 3.5, 28 millimeter drug-eluting stent. Now we move to the right, and you can see, so we have this GL 3.5 6 range with very poor support. And we're able to wire before any injection the left main, because I think it decreased the risk of complication. And then we start to pre-dilate with a 2.0 balloon because the 2.5 was not able to cross. So 2.0 semi-compliant balloon, relatively high pressure. You think there is still a waste on the balloon. Then we move to, so this is the result, which is quite the same. Then we move to a non-compliant 2.5. There is still some waste on the balloon at 24 atmosphere. So you think now we have a left main which is a little bit larger. And then because we are not able to move with a bigger balloon non-compliant, we decide to use rotablator. So 1.5 burr was very easy to use it. So now we have, after rotablator, improvement of the size of the left main with some residual waste at this level. So we decide to protect the Alaide, and it was very difficult. So in this case, we had to use a supercross 120-degree micro catheter in order to be able to wire the Alaide. As you can see, there is a big tortuosity. I think it was the best way to wire this Alaide for protection. Now we can use a 3.0 balloon, go to very high pressure, 24 atmosphere, and you see there is no residual waste. And we decide to use a large stent. And I was not able to go through, so I decided to use extension catheter, 6 French, in order to be able to use a Megatron 4.5 synergy balloon. It was the only way to put the stent in place. So now we are positioning the stent at the up to the ostium. Of course, it's and deploy the stent Now we are doing a proximal optimization technique with a 5.0 balloon. And this is the result, which I think very acceptable. You see that there is some pinching of the ostium of the Alaide. So we decide to open the strut toward the Alaide, but don't do kissing balloon inflation in this particular case. So wire the Alaide again, open the strut, and we have done pot side pot. And this is the final result, which I think is very acceptable. So this is a comparison of the before and after. So the in-hospital outcome was excellent. So the intra-aortic balloon pump was removed on the table, closure with ProGlide. She had no cardiac failure, no acute kidney injury. The echocardiography the day after was very good. And she was discharged at day 2 with a classical treatment after PCI. So my take-home message for this particular case is that in this very old patient, even if the lesions are complex, medical treatment is not an option. And we learned that many years ago at the era of bare metal stents. We understood that if we treat this patient with medical treatment, the risk of death at 1 year is more than 30%. Strategy is very important in this kind of complex case, and companionage also. And I think it's very important to discuss before doing the case about all the steps of the procedure and which can be the good plan and the plan B or even C sometimes. It's very important also to know how to solve difficult branch access. You have seen the difficulty with this Alaide in this case. And I think in left main, proximal optimization technique is really a part of the procedure and very important, whatever the technique, with 1 or 2 stents. 6 months later, I received a letter from the patient, and she was saying that she's very happy to be back to a normal life, and she's driving again his car. Thank you very much for your attention.
Thank you, Thierry. Excellent. We saw 2 nice cases. I think we have some time for discussion, 10 minutes. So please welcome any comments, suggestions, whatever.
So may I pose one question for the first case? Having seen what then happened, clearly, first of all, congratulations how you managed the case, went through the complication, and what would you have done differently? You know, if you had the possibility to do this differently, what would you have done from the beginning? What about sport? What about something else? Wiring?
Yeah, definitely. So this case, there is some ambiguity looking at the spiral view. Distal limb main relatively okay, and 3 relevant branch, Alaide, ramus, and suck. And the suck ostium relatively looks good. So initially, to reduce complexity overall procedure, I just put the wire Alaide and ramus branch. So I think the key lesson for this case, if you're gonna do any complex region, limb main equivalent region, I recommend put the all wire Alaide, ramus branch, and the sucker branch. And I think that this case is a very good luck to wire pass to sucker region. But at the initial time, patient was compromised. Is a wiring take 4 minutes, 5 minutes. At that time, I'm very perplexed. But this case is very lucky case.
Perhaps I could make a comment. It was a great result. Perhaps if I'd been doing it, I would. And one of the great things about our specialty is that there's no right and wrong. Sometimes it's just a question of choice. I would probably have taken the Alaide first, and I might have rotablated the Alaide. I guess one of the challenges if you do the intermediate first, and particularly if your stent ends up being quite close to the left main, you might have then concerns about rotablation into the LAD if you don't know whether the LAD will expand, and that would perhaps be as you show that once you start, the case kind of runs along, doesn't it? And I perhaps would have wanted to be sure that I could expand the LAD first, but you got a fantastic result. And I think the other thing which is very important, and you showed beautifully, is how in the trifurcation, the angiogram really can't assess the result. You know, you need to use imaging, the IVUS or OCT, to show that you've really got a good result in in the ostia of all those vessels. And that was a beautiful demonstration of that.
Thank you. Great comment.
Yeah, one thing I would have done differently, I would have used a drug-coated balloon for the intermediate and a single stent for the LAD without covering the left main. So I think it's beautiful to see how different you can approach a case, but whatever approach you take, you have to be ready for plan B, because not always things go the way you would like to go. So again, thank you for bringing us again to the reality and telling that what we wish is not always the case. Thierry, can I ask you a question? I think I've been a little bit reluctant to stent towards the circumflex, but I think you did the right, because the bulk of the plaque would have distorted the stent a lot if you stented the LAD. And I think your case made me change my mind. And if I stented from left main to the LAD, the stent would have been deformed too much, and the right approach was to stent towards the circumflex. So at the beginning, I would have done differently, but you made me change my mind. Thank you.
Thank you, Antonio. I think you're right. Before doing rotablator, we're not sure in which direction we'll go. But after looking at the difficulties that we had to go in the LAD with a wire, I realized that it was the only way to do it properly, because we will have, as you said, a big distortion of the stent, and maybe we'll have a lot of difficulties to reach the LAD. As you have seen, I had to use extension guide to put the stent from left main to circ. So it was really challenging. But as you said, it's very important to have a good plan at the very beginning, and the plan B also, and sometimes C.
I think perhaps the
Thierry,
structural
all right,
work has kind of encouraged us to plan a bit more than perhaps we used to. And I think the thing that was noticeable for me was you did the right, you got the balloon pump in, and that you were ready to deal with trying to keep ahead of the hemodynamics in someone with a bad ventricle. Because as you know, particularly with rotablation, and rotablation was always quite likely, really. If you get into that slow flow position and you haven't got pressure, then you end up in a mess, don't you? So, and a great result. And I guess the other thing which was interesting was sometimes you set out to think, I will try and wire the LAD, and you're just not going to be able to do it until you've adjusted the plaque or tried to treat the plaque, and that gives you the opportunity. So trying to keep ahead of the case and making sure that you were getting flow into the left coronary was obviously really important right at the beginning there. So great result.
Mm-hmm. All right. Okay. To the Thierry cases, actually, I would like to ask why did you choose the circumflex rather than the LAD? I want to choose the LAD and the main stem of fever. If you look at the right coronary artery, circumflex is balanced one. Still, I believe LAD supplied more, major artery. And second one, actually very old. It's just banning a measure about that low ejection fractions. Any cases, rotablation can make a bit worse in terms of microembolism, something like that. And so, if it works, balloon, if you do did a 2-5 balloon, right? And almost all cases we did, bigger balloon, high pressure inflation can make us more effective, lesion areas. And so I want to just ask them, the rotablation used for those, low ejection fraction and still Alaide remains, then would be preferred for us. Could you explain that one, Thierry?
Yeah. In fact, we plan not to use rotablator, but we knew that maybe we'll have to use it. So rotablator was ready, but my plan was to avoid using rotablator if I will be able to open the lesion correctly with a non-compliant balloon at high pressure. And in fact, it was not the case. So I had to use rotablator just to break some calcium in order to be able to expand the lesion with the balloon and then the stent. Then for the discussion between Alaide and Circ, of course, Alaide in this case is probably more important than the Circ, but it's a 1-0-0 lesion. So we can go in the Circ or in the Alaide. I think it's not so important. If we put the stent first in the Alaide, the risk is that we will need 2 stents. If we go in the Circ, I think the need for 2 stents will be very low. So it's one of the discussions that we have regularly, how to treat properly the case with 1 stent. And in this case, the best option was to go in the Circ.
So
Great.
I'd like to ask you. I'd like to ask to the Dr. Lefevre. Congratulations, your nice result. I'd like to ask you how to select a treatment sequence. So RCA, there is some region and left main tight lesion. So which should be treated first in your practice?
Yeah, I think it's a very important point, and we had a long discussion about that because if we treat the right and then we have a complication on the right, the patient will die on the table. Yeah. But if we treat the left main without with a poor hemodynamics, again, it will be very difficult. So because the lesion was relatively simple on the right, we decided to go first to the right. But of course, for each case, we have to discuss what will be the best in terms of safety of the procedure.
Okay, thank you very much. I think in the interest of time, we need to move to the next set of presentation. What you agree, Dr. Park?
Yes, I really. I'd like to introduce Gregg Stone. He will give us main topic of lectures: Excel trial, extended long-term, and key clinical studies. Gregg, please.
It's really a pleasure to participate, and hopefully now you are seeing my slides.
Great.
So it's a great to be at this virtual meeting. I wish we were all together. I missed my yearly trip to Seoul for the great TCTAP meeting, but this certainly is the next best thing to see all my friends. So we'll talk today about the extended long-term results from the Excel trial. I do have relationships with many device companies, but I don't have any relationships with any stent manufacturers relevant to this talk. So as you recall, Excel is the largest left main randomized trial to date. We screened 2,905 patients with unprotected left main disease. We took those eligible patients with a visually estimated syntax score in the lower intermediate range, and then randomized them 1-to-1 to PCI with the Xience everolimus-eluting stent versus bypass surgery. And at 1,905 randomized patients, this was the first trial that was powered for the primary endpoint of death, myocardial infarction, or stroke. I'll remind everyone that Excel was an academically driven trial with an equal number of cardiac surgeons and interventional cardiologists, and we all agreed certainly that these 3 endpoints were much more important than revascularization or any other quaternary endpoint that we could measure. One of the interesting things in the baseline findings relevant to some of the other findings was that even though we intended to only enroll patients with low and intermediate syntax scores, as you could see by the site-reported rates on the left, By core lab analysis, as we've seen in other studies, the sites tend to underestimate the syntax score. So approximately a quarter of the patients actually ended up with high syntax scores in this trial. So these are the overall primary endpoint results out to 5 years. And right now, 5 years is the longest follow-up that is planned in Excel based on funding. And the primary endpoint of death, stroke, or MI, and this was large MI, by the way, you could see we have PCI in orange and CABG in blue. And early on, you could see that there were fewer major adverse events in the PCI group compared to the surgical group. Then there was a catch-up right around 2.5 years. And then long-term, you could see there were fewer events in the surgery group compared to the PCI group. But at the end of the 5-year period, there was approximately a 3% difference in adverse events between the groups, and the odds ratio is 1.19, so these were not statistically significant differences. Now, if we look at pre-specified subgroups, this is a very complex slide, so I'll just emphasize a few of them. Diabetes, of course, has always been an important point, and you can see the relative differences in death, MI, and stroke between PCI and CABG were almost identical in diabetic and non-diabetic patients, so no significant interactions. If we look at whether or not the distal left main was involved, in about 80% of the cases there was a distal left main bifurcation disease, again, no significant interaction between outcomes in the presence of that parameter. If we look at the number of non-left main disease coronary arteries, you could see, again, no significant interaction. Even patients with left main plus triple vessel disease had similar outcomes after PCI and CABG. And finally, if we look about the syntax score, and this is the core lab assessment of the syntax score, you could see also no difference in relative risk. Perhaps you see a slight trend, low syntax scores, really identical relative risk. Then as the syntax scores go to intermediate and high, maybe a slight trend, slightly favoring CABG, but again, not statistically significantly different, and the difference in absolute rates was also not large. Now, importantly, when you look at these 5-year data, and we saw the same thing in the ischemia trial, you have to recognize that this curve is a now classic example of what we call non-proportional hazards. That is, the curves are crossing. The hazard ratio is not the same early as it is in the middle of the trial as it is in the late trial. And so frankly, a hazard ratio is inappropriate when you don't have proportional hazards. And that's why we've had to analyze this by an odds ratio as opposed to a hazard ratio. So how do you calculate the overall risk to the patient when you've got these crossing event rates? Obviously, if you're going to have an event, you'd rather have it early. You'd rather have it late rather than early. But if you have it early, then the event lasts, if you will, affects the patient's rest of the life. If you're going to have an event such as an MI or a stroke, you'd rather have it late. Well, the first thing you do is you look for the periods to see where there are proportional hazards. And we actually found 3 different curves within the curve, if you will. Within the first 30 days, there were clearly fewer procedural events with PCI compared to CABG. And again, this is death, stroke, or large MI. So you could see approximately a 40% reduction in adverse events in the first 30 days. Then from 30 days to 1 year, the quote restenosis period, the curves were superimposable. So proportional hazards, again, with an odds hazard ratio of around 1. And then after 1 year to 5 years, you could see that there were fewer events in the CABG arm than the PCI arm, and you could see that these curves continue to diverge over time, approximately a 60% difference. So again, how do we integrate these results overall? Well, again, taking into account that you would rather have an event late compared to early, because that impacts the patient's lifetime perspective to a lesser degree. You can look at a parameter called the restricted mean survival time, which is basically the area between the curves. And this is the difference in the event burden, which favors the PCI cohort. This is the difference in the event burden that favors the CABG cohort. So if you look here at the difference in event-free survival, you can see early on after PCI, the average patient is having more and more average event-free survival, but then the late bypass advantage starts eroding into that. So at the end of the day, you can see the PCI patients had 5 days of event-free survival more than the CABG patients, but you can also note the confidence intervals in these dotted white lines, and here's the data. So it's clearly not a significant difference. So overall, the overall adverse event burden was very similar in PCI and CABG patients. Now, let's drill down a little deeper into the data. First, if you look at the outcome at 30 days, you could see that there was no difference in mortality. Mortality very low now in these patients, 1% with both procedures, which is excellent. In-hospital stroke was lower with PCI compared to CABG, and at 30 days, it tended to be 50% reduced. The biggest difference, though, was in myocardial infarctions, and these were really large MIs, Q-wave MIs, and STEMIs, and these were really due to a difference in graft failure. There was more early graft failure than there was stent thrombosis. Now, we had a pre-specified endpoint called major adverse events that the surgeons and interventionalists agreed upon within 30 days that were, we considered relevant events beyond just death, stroke, MI, and repeat revascularization. And this includes major bleeding, transfusions, atrial fibrillation, VTAC, VFib, repeat procedures, acute renal failure, sternal wound dehiscence, sepsis, et cetera, et cetera. And you can see overall, this was about 72% reduced in the PCI arm compared to the CABG arm. So this just, everyone knows that PCI is a much less morbid procedure than CABG, but this really, I think, quantifies the extent of that. Now, if we go to 5 years, we see something quite different. So here we see the no significant overall 5-year differences. And you'll note here that these are the differences, absolute differences and odds ratios. You'll note that there are no p-values on this slide. And the New England Journal, I think appropriately, does not allow p-values for anything that was not a powered endpoint, because none of these differences were corrected for were adjusted for multiple measurements by Bonferroni or any other technique, et cetera. So there certainly can be chance findings, and we looked at more than 35 secondary endpoints. Nonetheless, when we look at some of the interesting findings, we see that there was an excess in all-cause death in the PCI arm at 5 years, and this became positive between 4 and 5 years with PCI compared to CABG. Now, when we look at the adjudicated causes of death, we see that cardiovascular death was not significantly different, very close. This is 5 years now, so very similar rates. And that was very consistent with the similar rates of all-cause myocardial infarction between PCI and CABG. You would expect a difference there to translate into a difference or lack thereof in cardiovascular death. Rather, the difference in deaths were due to non-cardiovascular deaths. And when you look at the causes of non-cardiovascular deaths, and these were by conservative adjudications by a CEC, it was really due to infections and due to cancers, which were excess, and these occurred usually between 2 and 5 years after the procedure, suggesting that they might be due to play of chance. So in this regard, when you do look at secondary underpowered endpoints that you are concerned may be due to play of chance, but also may be real, this is where it is useful to take the totality of the data. And Excel was not, even though it was the largest, it was not the only randomized trial. In fact, there's 3 other major randomized trials of PCI DES versus CABG in left main disease, and that's Noble, Syntax, and PRECOMBAT. And here you can see overall in this updated meta-analysis at 5 years, there's absolutely no difference in all-cause mortality. You'll note there is some heterogeneity between these studies, however, and actually it was the Excel that was the outlier. So that was the outlier. Perhaps I think it really supports the fact that it was due to play of chance, due to non-cardiovascular death. And when you remove Excel, then there's no heterogeneity whatsoever, again, suggesting that that was the outlier. Now, if we get to other 5-year endpoints, cerebrovascular events were less common after PCI compared to CABG, but ischemia-driven revascularization was more common after PCI compared to CABG. I will point out, though, that if you look at these differences, these are 5-year differences, and every single one of them, even if they're real, are relatively low in absolute frequency on a 5-year time horizon. Finally, there's quality of life, and we had a formal quality of life assessment up to 3 years, and you could see early on PCI patients within 1 month felt much better. CABG patients actually feel a little bit worse early on, but then there's a catch up. So by 1 year and 3 years, there's no difference in physical functioning or mental functioning. And if you look at angina frequency, we see the same thing, that there's a slightly better very early on reports of less angina after PCI compared to CABG. Probably some incisional chest pain is being misclassified as angina, I would guess. But then afterwards, the rates of angina freedom are almost identical. So in summary, I would say that left main, PCI, and CABG are two very different procedures. And for each individual patient requires a heart team discussion to explain to the patient the differences in outcomes and then take into account the patient's individual clinical and anatomic situation and their patient preferences. So PCI has early advantages of being less invasive, fewer peri-procedural complications, stroke, MI, AFib, bleeding, kidney injury, etc. Lower 30-day MACE and more rapid recovery with better early quality of life and early angina relief. Bypass surgery, on the other hand, has clear late advantages. It's a more durable procedure, especially as relates to ischemia-driven revascularization and myocardial infarction. There are fewer adverse events beyond 1 year. Overall, PCI and CABG, I believe in most eligible patients for both procedures. There are no significant major differences in long-term survival, overall composite MACE, or quality of life. So I think it's really up to the patient and their caregivers if both procedures are really amenable to decide which is best for the patient, strongly taking the patient's preferences into account. Thanks very much for this opportunity.
Thank you very much, Gregg. Very, very clear, and you stayed in the time perfectly. We go to the next presenter, is Duk-Woo Park from Asan. He will give us the 10-year result of the PRECOMBAT trial with a deep dive into the data.
Thank you, Antonio. So my talking is about the 10-year final report of a PRECOMBAT trial. It's deep dive. This is my disclosure. So, and as I mentioned, Gregg is a left main PCI, has a very long journey. At the initial time, the PCI with the balloon angioplasty, bare metal stenting treatment effect was not good. But over the 20 years, there was a evolution in PCI part and medication part. So, and the diminishing outcome gap between PCI and bypass surgery in left main disease over time. So random trial on revascularization continues to being matched from the Syntax trial, PRECOMBAT trial, BEST trial, and Excel and Noble trial still continue extended follow-up ongoing. So PCI and bypass surgery in left main disease this year, and as you mentioned, Gregg and low and intermediate risk PCI CABG showed similar mortality and serious composite outcome. This is in general, PCI was associated high risk repeat revascularization and low risk stroke and the major or operative complication compared to bypass surgery. However, game is just begun. And the one important thing, we are demanding very long-term, the 10-year result of PCI and bypass surgery for left main disease. Why we need very long-term data? There was some signal looking at main compared 10-year, Excel and Noble trial beyond the 4-year, 5-year. There was some, looks like a late catch-up or crossover, some signal. So reason why there are still limited very long-term beyond the 5-year comparative data PCI versus bypass surgery for left main disease in RCT, given that the trend of late catch-up and crossover still uncertainty about the very long-term outcome. It warrants additional long-term follow-up study. So PRECOMBAT trial initially evaluated 1,454 cases, 13 major centers in Korea participate, and clinical anatomic eligibility considered by cardiology and cardiac surgeon. Finally, 600 patients was randomization, PCI, first generation drug-eluting stent, cipher stent versus bypass surgery. 300 patient was enrolled. Primary endpoint was MACE. And looking at the 2-year and 5-year, 2-year result, there was a PCI was non-inferior compared to bypass surgery published in New England Journal of Medicine. 5-year report, there was no difference, MACE primary endpoint, mortality, and hard endpoint. And looking at the major inclusion criteria, we include de novo unprotected Lefevre disease potentially comparable treatment with PCI and bypass surgery. We exclude prior bypass surgery and acute myocardial infarction, and the ejection fraction was less than 30%. Primary endpoint was defined MACE and composite of any cause of death, myocardial infarction, stroke, and ischemic-driven TVR. Protocol definition MI used the PERI procedure. We defined the new pathology Q wave and the CKMB more than 5 times. After discharge, during follow-up spontaneous MI, we defined any CKMB elevation with ischemic symptom and sign. Ischemic-driven TVR was defined angiographic stenosis more than 50% with symptom or sign, or angiographic stenosis more than 70%. The secondary endpoint is hard endpoint, the death, MI, stroke, and any revascularization, definite thrombosis, or symptomatic graft occlusion. Although PRECOMBAT initially planned to complete the 5-year follow-up in original protocol, all participating center agreed to participate extended 10-year follow-up. In Korea, just a half-day circle of life, and most of the investigator agreed to follow up. Also, regarding to survival data, we linked to Korean National Health Insurance Service, and this data is coverage all Korean citizens, enrollment rate more than 97%. Looking at the baseline characteristics at the time of enrollment, and the 62-year-old diabetics 30%, and the hyperlipidemia is 40%. Prior MI is approximately 5% in both groups. CRF is 0.3%, and the clinical manifestation is half of patient presented stable angina or silent ischemia, half of patient presented unstable angina, recent myocardial infarction. Ejection fraction nearly normal, sinus rhythm was most commonly, and the Euro score 2.6, 2.8. And looking at the extent of disease vessel, Lefevre only is 10%, Lefevre plus 3 vessel, 40%, 41%. Distal Lefevre bifurcation involvement was 67%, 62%. Syntax score was 24.4 in PCI group, bypass surgery group 25.8 in bypass surgery group. High syntax score was approximately 20% in both groups. We achieved complete revascularization 68% in PCI, 70% in bypass surgery group. Looking at the brief summary of procedural operative characteristics, we used IVUS guidance more than 90%. Is a one-stand bifurcation technique used 46%. And looking at the bypass graft group and the use of left internal memory artery used 94%, and the off-pump surgery 64%. And the complete 10-year follow-up, we achieved nearly 96% in both groups. Looking at the primary endpoint of MACE, this is intention treat population. At 10-year, bypass surgery group 24.7%, PCI group 29.8%, hazard ratio 1.25, confidence interval 0.93 to 1.69. There was no statistical difference. And the composite of death, MI, stroke, bypass surgery 17.5%, PCI is 18.2%, nearly identical. Hazard ratio is 1.00. Looking at all-cause mortality, nearly complete follow-up 98%, bypass surgery group 13.8%, PCI group 14.5%, nearly identical. Hazard ratio was 1.13. And the ischemic-driven TVR was a bypass surgery group 8%, and the PCI group 16.1%, This is statistically significant. Ischemic-driven TVR was 2 times higher. So looking at the primary, secondary endpoints, there was no statistical difference. And the stent thrombosis or symptomatic left occlusion, PCI group 1.4%, bypass surgery group is 3.7%. So key subgroup analysis, we did not find any statistical interaction, just except the extent of disease vessel, left main plus 3 vessel, MACE bypass surgery was much better, but this is not adjusted for multiple comparison, so interpretation should be cautious. And this is as treated analysis, and the bypass surgery 21.8%. PCI group is 31.6%. This is statistically significant. Very similar per protocol analysis. Bypass surgery 21.9%. PCI is 30.6%. This is also statistically significant. However, our PRECOMBAT trial, random trial, per treatment analysis should be just interpreted as provisional. This is published in Circulation, and the editorial is Fernando Alfonso, Adrian Castrati suggests a very nice, some editorial. This is a proposed hot team discussion in current evidence-based in the left main disease and assess several clinical factor, anatomical factor, and the discussion with the hot team discussion, the recommended optimal the revascularization strategy. This is my last slide. In 10-year follow-up, PRECOMBAT trial with the left main disease, randomization, PCI, with drug-eluting stent or bypass surgery, there was no significant difference in instance of primary endpoint of MACE, all-cause mortality, and serious composite outcome. Given that the extended follow-up data of landmark clinical trial, Syntax, PRECOMBAT, Excel, and Novel trial are available. Further individual patient level data meta-analysis will provide the more strong scientific evidence and useful insight to better inform clinical decision making to select optimal revascularization for such patient. Thank you for your attention.
Thank you so much.
Next speaker, Patrick Serruys, will give us a long-term 10-year validation of the Syntax 2 2020 score. Patrick, please.
Thank you very much, SG. It's indeed a great privilege to be with everybody, with all good friends. So what we are going to do today is on behalf of the investigator of Syntax's Freedom, PRECOMBAT, and BEST. You have there SG Park, Duk-Woo Park, and Valentin Förster. We are going to present the Syntax Score 2 2020. The paper is in press in the Lancet, and it is an individualized decision-making score between percutaneous and surgical revascularization in patients with complex coronary artery disease, left main, and tri-vessel disease. So we have recalibrate all the score with these 3 gentlemen, 3 prima donnas in statistics and epidemiology, David Kent in Tufts in Boston, Wout Steyenberg in Leiden, and David van Claveren in the Erasmus University. Background, the RCT are the gold standard for testing the effectiveness of novel treatment. However, the average treatment effect are typically reported in randomized trial. And we must realize that treatment effectiveness can vary across individual patients. So the average treatment effect may be suboptimal for decision-making in individual patients. The Syntax Score 2 published in the Lancet in 2013 was derived from 2 angiographic and 6 clinical variables and provide at that time, for the first time, an individualized decision-making based on 4 years all-cause death after either CABG or PCI. Now, this time using the data of 10 years follow-up of syntax extended survival, syntaxes, we sought to update the syntax score to a version of 2020 for prediction of 10 years mortality, but also 5 years MACE, and to externally validate in freedom best PRECOMBAT that new score for its ability to predict treatment benefit in mortality and in MACE. Now, the average treatment effect has a summary result for 10 years all-cause death in the syntaxes is basically an whole-cause mortality of 28.4% for PCI taxus and 24.5% for cabbage. And you have an hazard ratio of 1.19, but look at the 95% confidence, it's a borderline. You may say an increase in relative risk of 19% with a p-value of 0.066. Now, based on the average treatment effect, should you send all your patients to surgery with that kind of result, of other result? No, the answer is, of course, no. But we are working on a decision tool to improve personalized care in cardiovascular disease. As you see, the average treatment effect is assessed in an heterogeneous population. You may have a patient who derive benefit from the treatment, the small green guys. You can have in blue patient who have equivocal of equipoise response, and you may have patient harmed by the treatment. And the average treatment effect will produce a small multicolor individual, green, blue, and red. So what we have to do more and more is identify heterogeneous response to the treatment. We have to segregate the patient population based on treatment response and see who is going to be harmed by the treatment, who is going to benefit from the treatment, and who has equipoise. Now, the syntax score 2 published in The Lancet in 2013 was developed by applying a Cox proportional hazard model to the 4 years result of the syntax trial, resulting in a combination of 6 clinical and 2 anatomical independent predictors of 4 years all-cause mortality. So you have here the anatomical syntax score, independently the left main, the age, the creatinine clearance, the ejection fraction, COPD, peripheral vascular disease, and female. Now, I put female in the red because what is interesting is that over time, as you could see at 4 years, female randomized to cabbage in yellow had a lower all-cause mortality than female randomized to PCI. But at 10 years, all-cause mortality rate in female PCI of cabbage were identical with 33%. And in male, all-cause mortality started to diverge after 7 years. Now, the new syntax score was redeveloped, recalibrated to predict not only the 10 years mortality, but maybe which is more relevant for the physician, the clinician, the 5 years MACE in the syntaxes trial, and externally validate in the freedom, best, and PRECOMBAT trial. And you see that diabetes made its entry, and current smoking make also its entry. That's unavoidable. That's a fact of life. Now, what you see at the bottom is the probabilistic formula to predict the 10 years mortality. If the patient is going to go, if the patient is going to go to surgery, if you intend to go to surgery, you will apply that formula with the blue numbers for cabbage. On the contrary, if you intend to go to PCI, then you will use the parameter in red of PCI. And you will have not only the 10 years mortality, but also the 5 years MACE. Now here we have the cross-validation of these 10 years mortality in the syntaxes. On the left-hand side, you have the observed 10 years mortality versus the predicted 10 years mortality. And you could see that applying the model for PCI or applying the model for cabbage, you have a pretty nice linear relationship. It is amazing. The slope is close to 1. The intercept is close to 0. And you could see the whole population has been divided in quartile. Now, what is interesting is that in the first quartile, basically PCI is doing better. In the second quartile of the population, there is equipoise. In the last 2 quartiles, that's the half of population, cabbage is doing better. Now let's translate that in Kaplan-Meier curve. And now you see in the first quartile, PCI is better. The survival of PCI in red is on the top of the survival of the surgical case. And as a matter of fact, the absolute risk is in favor of the PCI. When you go to the equipoise group, the Kaplan-Meier curve is, of course, completely superimposed, overlapping. And as you could see, the absolute risk difference is around 0.3%. Now, in the last 2 quartile, surgery is better. You have a better survival, the blue curve of surgery versus the red curve of a PCI. And you can see that the absolute risk difference is around 11.4% and 6.1%. That was for 10 years all-cause mortality. The beauty is that almost the same model can be used now for 5 years MACE, which is much more relevant. It's a little bit more difficult, again, looking at the observed 5 years MACE and the predict MACE. You have a very nice relationship, linear, but the slope is less than 1, and there is some intercept. That's also true for cabbage. But again, the difference in 5 years, called now treatment benefit of cabbage versus PCI, is quite nice. And you see here the absolute risk difference. So this is my last slide. That's the app for using the syntax score 2020. Let's take the first case. The individual is 74 years old. He has no diabetes. Creatine clearance is below 60 ml, 38.6. Ejection fraction is no longer what it used to be, 40. Is a current smoker. He has a main stem, but a relatively simple main stem since the anatomical syntax score is 11. That's almost an isolated left main. And you see that in this case, the PCI has a 10 years mortality of 57. Don't forget, the individual is already 74 at the time of the procedure, but surgery is worse, 10% worse, 67.9. If you look at the MACE 5 years, the difference is about 13-14%, 30% for PCI, and 43.9 for a cabbage. So in this patient, it will be recommended to go to PCI. Let's take the case number 2. You have a quite young patient, 49 years old. This time he has diabetes, but not insulino-dependent. He has a reasonable clearance. He has a good ejection fraction. He is a very simple 3-vessel disease with anatomical syntax score of 10. This is all real case, of course. And as you could see, we have équipoise. We have équipoise in 10 years mortality, 11 and 10%. Is 59 years old. And in terms of MACE, 9.3 and 8.4. And the last case, as again, a little bit more elderly, 69, but diabetes, insulino-dependent, creatine clearance is quite reasonable for that age. Ejection fraction is okay, 55%. He has a 3-vessel disease, but a terrible 3-vessel disease with an anatomical syntax score of 50. And you see that with PCI, you will have a mortality at 10 years of 49% versus 28% for the PCI, for the cabbage. And conversely, in 5 years MACE, the mortality with PCI will be 38.8%, and the mortality with cabbage will be 18.4%. So that individual has to go to bypass surgery. It is ethical, it is almost mandatory. So in conclusion, using data from the randomized syntaxis trial, we have updated and externally validated the syntax score to 2020, which is a personalized predictive model based on 7 prognostic factors and 2 pre-specified effect modifier. The type of disease, 3-vessel disease, and left main being quite favorable for PCI. And then on the other effect modifier is the anatomical syntax score, which is still robust these days. And with that, we can predict the 10 all-cause death, but also the 5 years MACE for patients treated with either PCI or cabbage. So by providing expected probabilities of 5 and 10 years outcome, this model may improve the ability of the heart team to inform patients and their families regarding the risk and benefit of alternative treatment for complex coronary artery disease and support a more transparent shared decision-making process. Thank you very much.
So the last presentation of today is Dr. Chen from Nanjing in China. And as a bifurcational expert, he will give us update about the definition 2 trial.
Oh, thank you, SJ Park, for providing me this opportunity to present my recently published definition 2 trial. It's a multi-center randomized comparison of 2 sedan and provisional stenting techniques for patients with complex coronary bifurcation lesion. So this is my disclosure. So why we designed this study? So in general, previous study have confirmed the high rate of clinical events after stenting coronary bifurcation lesion compared to stenting in non-coronary bifurcation lesion. In 2018 ESC guidelines has stated that 2-stent approach may be preferable for complex bifurcation lesion. However, obviously, unfortunately, so far there is no universal definition to define the complexity of coronary bifurcation lesion. On the other hand, in 2015, we for the first introduced the definition criteria, which could define the complexity of coronary bifurcation lesion, but it has not been tested in any randomized clinical trial. So this is the aim of this study, to compare the treatment effect between provisional and 2-stent strategies for patients with real complex coronary bifurcation lesion defined by definition criteria. So inclusion criteria are same as our previously published DK criteria 5 study, and also we follow the inclusion criteria in general, particularly if the patient can MI older than 24 hours prior to treatment, Another point is that only Medina 111 or 011, two types of true coronary bifurcation lesions were included in this study. So this is a slide to show the brief introduction of definition criteria. So in general, on the left box, you can see there were two major criteria to define the complexity of complex coronary bifurcation lesion. Simply, for a bifurcation lesion localized at the distal left main, so if the side branch lesion length minimal 10 mm and the side diameter stenosis minimal 70%, for bifurcation lesion localized at the non-left main, distal left main, so the same criteria for the side branch lesion length, but the side branch diameter stenosis should be minimal 90%. Except for major criteria, we also have 5 to 6 minor criteria on the show on the right box. So including mild calcification, multiple lesions, bifurcation angle, is a main vessel, reference vessel diameter less than 2.5 mm, main vessel lesion length minimal 25 mm. Also, if there is thrombus containing lesion. So finally, any one major criteria plus any two minor criteria, so the bifurcation lesion could be defined as complex bifurcation lesions. Exclusion criteria similar to our previous exclusion from DCAP 5 study. So particularly, if more than 3 stents were likely to be needed to treat the bifurcation lesion. For example, if we need 2 stents for main vessel lesion or 2 stents for side branch lesion, so such very diffuse lesion will be excluded from this study. So there are no specific difference in the general exclusion criteria from this study to our previous DCAP 5 study. So this is the endpoint and assumption for this study. So the primary endpoint was the tidal lesion failure at 1 year follow-up after standing procedure. Our assumption was that the 1 year TF rate was estimated to be around 14% after provisional standing and 7% after 2-stent strategy at 1 year follow-up. So finally, a total of 660 patients was required in order to achieve 80% power to side alpha of 0.05, as well as 10% loss to follow-up. So study flow chart, finally, there were 325 patients in the provisional group, versus 328 patients in the 2-stent group, except for the primary endpoint. Study flowchart also show the safety endpoint was the stent thrombosis at 12 months follow-up. Also, we included some different secondary endpoints, including all-cause death, cardiovascular death, incident with stenosis, myocardial infarction, clinical-driven TLR or TVR. Angiographic follow-up was scheduled at 13 months after the procedure, but it was optional. So table shows the baseline characteristics non-significant difference between two groups. Particularly, you can see almost 70% of patients presented acute coronary syndrome. Diabetes was seen in almost 35% of entire cohort of patients. Previous myocardial infarction was recorded in almost 12% of the patient. Almost 17% of patients had previous PCI. Chronic heart failure was not frequently seen in the patient. So particularly, you can see of our patient, almost 22% of patients had acute myocardial infarction older than 24 hours, but without significant difference between two groups. So this table shows the distribution of lesions characteristics in two groups. In general, only 20% of patients have higher syntax score more than 32 scores. Particularly, you can see from the table. So almost 29% of patients had distal left main bifurcation lesion. Side branch lesion length was around 20 millimeters in 2 groups. Finally, multivessel disease was seen in almost 60% of the patients without difference between 2 groups. Interestingly, even all the patients were defined as a complex bifurcation lesion according to on-site assessment. But if all lesions were assessed by Colombo, so the percentage, the real complex bifurcation lesion was around 92% in 2 groups without significant difference between groups. Most importantly, you can see most of the bifurcation lesion were defined by Medina 111, with only 13% of patients who had Medina 011 bifurcation lesions. So from the procedural characteristics, you can see transradial was more commonly used in 2 groups. Interestingly, in provisional group, side branch predilation pre-treatment was only used in less than 50% of the patient. So I do believe almost all of the operators followed the study protocol. Finally, two-stent technique was used in 92.1% in the two-stent group. It means not all two-stent, all bifurcation lesions in the two-stent group not treated by a two-stent technique. On the other hand, finally, the side branch stent was used in 22.5% in the provisional group. So that means the crossover rate from provisional to two-stent in the provisional group was almost 23%. So finally, DCAT quality was used, and the TAP was popularly used in the provisional group. Finally, after kissing balloon inflation of the two-stent, so the proximal optimization technique was only used in less than 90% of the patient in the two-stent group. It's a little bit higher in the provisional group, but there was no significant difference between 2 groups. So 1 year clinical follow-up showed a significant high rate of TLR and T target vessel myocardial infarction in the provisional group. So they were 5.5% of TLR, clinical driven TLR in the provisional group, and 7.1% of target vessel myocardial infarction in the provisional group. Significantly different to 2.4% of TLR and 3.0% of target vessel myocardial infarction in the two-stent group. So finally, there was significant difference in terms of the 1 year target lesion failure, which was 11.4% in the provisional group compared to only 6.1% of the two-stent treatment. However, by 1 year follow-up, there was no significant difference in terms of the all-cause deaths, cardiac deaths, or definite stent thrombosis between 2 groups. So this is the survival line, shows the significant difference in terms of the TLF-free survival at 1 year follow-up between provisional and two-stent group. So from the figure, you can see the 2 lines separated each other very soon after the procedure. So it means a very high rate of target vessel myocardial infarction of the procedure. After 7 months, there was a second wave of increase of the clinical events, mainly driven by high rate of clinical driven TLR in the provisional group compared to two-stent group. So in conclusion, systematic two-stent has less rate of 1 year target lesion failure for patients with definition criteria defined complex coronary bifurcation lesions compared to provisional approach, mainly driven by reduction of target vessel myocardial infarction and clinical driven TLR. However, incidence of the stent thrombosis was comparable between 2 groups. So probably it may suggest the benefit of decay quality for real complex coronary bifurcation lesion. However, the underlying mechanisms for the increased target vessel myocardial infarction after provisional stenting are unclear so far, and the first study is warranted. This study just published in the European Heart Journal last month. Thanks for your attention. Thank you once again.
Excellent presentation. I think we have a little bit of time for discussion. We are a little bit over time, but I believe that the topics are so important that we can keep 10 minutes for discussion.
Oh, may I pose some questions? I try to be short for each of the speaker. The first is to Gregg on the Excel. Do you think it is worthy to have an extended follow-up of the Excel?
Thank you, Alaide. Yeah, I would love to have an extended follow-up from Excel. And unlike the other studies, we actually did consent all the patients for 10-year follow-up. Unfortunately, the sponsor has decided they only have funding for 5-year follow-up, and at this time, the study has been closed. So we tried very hard to look for other sources to see if we could get extended follow-up, but it just was not possible.
Okay, because you know how they did with the syntaxes? Actually, it was a kind of investigator-driven effort, and all of us participated. I mean,
I must say I'm impressed.
Very interesting information, by the way.
I'm impressed by, in both syntaxes and in PRECOMBAT extended, that the curves really remain quite parallel from 5 to 10 years. You know, there's always the thought by the surgeons that that's when the real benefits are going to be evidenced. But on the other hand, that's when grafts start failing. Now in Excel, we saw the curves diverging from 1 to 5 years, at least for death, MI, and stroke. So I certainly would have liked to have seen if those would have continued to diverge, became parallel or converged, but unfortunately we don't have that option.
Okay. A second question for Professor Serruys, clearly on the female sub-analysis. Do you think that how can you interpret these? It's more for cardiovascular mortality. How can we interpret the finding that you had on the female patient that actually is different from other studies?
Yeah, I think that what we have to say up front is that the female enter into the trial at a higher level, at a higher age, sorry. So I think that by memory it was 69 versus 65 for the men. So 10 years later, they are getting close to 79, 80 years old. So you have other cause of death than the cardiovascular cause. But I think it's clear that it's not the only surprise that we have with these very long-term follow-up. At the end of the day, everybody died, that's for sure. But I mean, you see in women, you have this strange phenomenon of the curve joining the female PCI at a certain point. In diabetes, we see the same things. At the end, there is basically no difference with diabetics. I mean, that except maybe a trend for the insulino-dependent. So that, I think that the remark made by Gregg is correct. I mean, I think that if the surgeon have supported 10 years of syntax, it is a grant from the surgeon coming from Germany, is because they were systematically expecting the divergence of all these curves. And I think that we are going to see more frequently is that the curve finally rejoining of converging after a moment of divergence. So we have to be very, very careful when we talk to the patient, if we talk about a 3 years prognosis, a 5 years prognosis, of a 10 years prognosis, and it depends very much the age of the patient at the time of the discussion.
So Patrick, can I add something as well? You know, I think that one thing that's been missing in this discussion is absolute risk as opposed to relative risk. So, for example, even if you identify a patient that has a 5% difference in mortality at 10 years, and the p-value is 0.001, so you are convinced that that individual patient is likely to have on average, 5% higher mortality at 10 years. That's 0.5% per year. And I don't think we can be prescriptive to patients. Personally, I would rather not go through 2 months of surgery and the recovery of all of that and the discomfort and the disfigurement, et cetera, for that chance. 19 out of 20 are going to get the same result in terms of survival at 10 years. So I think we have to explain the time frame, the time perspective, and the relative risk, average per year, and where the average patient will be, and what the likelihood is of getting the bad result. You showed one example where there's a 20% difference in mortality at 10 years. That one I agree, that's quite compelling. But for 3%, 5%, 7% over 10 years, we have to explain that to the patient.
I could not agree more. Basically, when we introduce a new treatment, pharma of surgery, and so we have two goals: to prolong the life of the individual and satisfying his quality of life. That's it. Okay, if you think about it, if you think about yourself, over 10 years, you can play your 18-hole golfs and you are alive. That's the basic problem. Now, after that, you have the opposite. You have physicians which are dictating a treatment on a binary way. I've seen the last study with a difference of 4%, so I go now systematically binary. And in the Far East, what you see frequently is patient refusing surgery for all kind of reasons, cultural and so, but I'm not sure that they have been informed about the potential difference in prognosis. So I think it's a small step in the right direction. I mean, we are going to have more and more precision medicine. And you're right, it's very difficult to evaluate. I mean, as you say, 20% will convince everybody, but 5% spread over a period of 5 years, over a period of 10 years doesn't make difference. We are systematically now calculating the life expectancy. And it can be 5 days, but it can be also 1.5 years, 1 or 7 years. What does it mean if your quality of life is not there? So I agree with you. It's a complex issue when you have with an individual patient. There's many other things, but it's a small step forward that we get some calculation that we can use in our discussion eventually with the patient, but certainly with the colleagues. Yeah.
Great.
Patrick,
I have
the other comment I was just going to make is it also is going to depend on the center. And I think particularly for PCI, the operator experience will also have to be factored in particularly in complex disease.
Yeah, I agree with you. You remember this famous slide of Keith Dawkins that we said we will never publish in syntax, but finally the fiction went out. They were centers with, at least at 1 year, 0 event in surgery and 0 event in PCI in 40 patients, 2020. And they were people with 100 in PCI. So I fully agree. I mean, medicine is something which is local, regional, and it's very tough to put that in the equation, believe me.
I have a quick question for Dr. Chen.
Hi.
Can we identify in your study patients or lesions where there is no difference in the target lesion failure between provisional and 2 stents, or maybe even provisional is better? Because I'm sure that there are some subgroup or some type of lesions where the difference is minimal. And this will be very useful because as always, provisional simplifies many things. And to go to 2 stents routinely, it's a little bit moving back to the past.
Yeah, I think thank you for your great question. I think we do have many subgroup analysis from our paper. So in the two-stent group, we also compared the different two-stent technique. But you know, I think the sample size and the power to provide the convincing data. In the provisional group, we also compared the one-stent and final two-stent subgroup. Also, I think my concern is also the small sample size to get the final conclusion.
You know, because I have difficulties to accept to put two stents routinely when you have 70% of the lesions who are not distal and they are not true bifurcations. They've only.
Yeah, but you know, from our study, the minimal side branch lesion length was 10 millimeter. It means a pretty long side branch lesion. But for this left main bifurcal lesion, the side branch diameter stenosis is minimal 70%. But for non-left main bifurcal lesion, the side branch diameter stenosis should be minimum 90%. It means very severe stenosis for non-left main bifurcal lesion.
It's an important point that these were complex bifurcations, and the technique appears to have been quite aggressive in the side branch group. And as you pointed out, quite a lot of the difference is in procedural myocardial infarction. The definition of myocardial infarction was quite stringent. It was similar to Excel with a CK-MB of more than 10. So it's quite hard to understand why the provisional infarct rate was so high. It obviously was, but I do wonder why it was so high. And I guess some of the encouraging data is a reflection of our improved technique and improved stent safety and improved stent performance in two-stent approach. But the procedural infarct rate for provisional is kind of unexplained to me.
Yeah, I think it's a very, very critical question for the high rate of target vessel myocardial infarction of the provisional stenting technique. So far, we don't have very strong data to get the final postulation. So during the process of this study, we also perform a small intravascular study to try to identify the reason. So recently we just published our OCT analysis. So my postulation is that probably high frequency of vulnerable plaque around the POC area for real complex bifurcal lesion. So let me back to the first case by Dr. Park. According to the IVOS image from Ramos, so there was a very, very typical calcified nodules at the osteoid towarding a osteocentric flex. I think this will be another very strong evidence to support the routine use of two-stent technique. Thank you. May I have a question? Dr. Park, for your presentation, I have one question. So if ischemic-driven TVR was removed from the primary endpoint, is still significant difference between two groups, between PCI and KBG?
Yes, so I think for our PRECOMBAT trial, there was the cautious interpretation is initially our PRECOMBAT trial. Nowadays, practice pattern was changed. The PRECOMBAT trial designed nearly 15 years or 10 years ago. At the time, in protocol, we do routine angiographic follow-up in PCI arm. So the ischemic-driven TVR was defined 50% and ischemic sign and symptom. Also, regardless of any symptom and sign, we defined angiographic 70% stenosis. Because we do routine surveillance and coronary angiography, ischemic-driven TVR rate is much higher. But nowadays, we don't do that. So I think, in our practice now going on, I think the rate of ischemic-driven TVR is much, much lower in contemporary practice. Yeah. So we should interpret our protocol, define the recommendation routine angiographic follow-up in PRECOMBAT trial.
Thank you. May I have another question for Professor Serruys?
Sure.
Hi. Patrick, because from your new model, so female and peripheral artery disease were removed from the syntax model, and diabetes and current smoking were included in your new model. So did you test the overfitting of your new model from the validation group?
Yeah, first, it's only the women which has been removed. The peripheral vascular disease is still there. Yeah.
I'm sorry.
Yeah. And, you know, it's interesting because there is a classical approach dating 10, 15 years where you go to area under the curve using the C statistic for the prognosis. What I have seen the last few years with the epidemiologists is no longer talking about the risk, but the benefit, and going much more in the direction of correct calibration. I think they really get obsessed by the relationship between predicted and observed. And I must say that watching them for a few years, not only in the field of cardiovascular, I realized that it is indeed a very, very powerful instrument. And you know, like every linear regression, I mean, you have the slope, you have the intercept, and you have the distribution of the point around the so-called identity line. And I'm becoming more and more confident about that versus what has been done before on C statistic. C statistic, basically concordance was something which was for the diagnostic technique. You have angina. Is your thallium scintigraphy positive in the next 30 days? That was, and the 30 days was very important. And it has been a misuse of the C statistic in the prognostic thing. So I don't think that it's overfit, because basically the basic principle is the calibration concept. Yeah.
Thank you, Gregg. I personally think for the comparison of PCI versus cabbage for left main disease, personally, I don't think inclusion of TLR or TVR is unfair for PCI. So what's your opinion?
No, I agree with that on a variety of levels. First of all, there are differences in repeat revascularization after PCI compared to cabbage. They're not the same procedure. We almost expect repeat revascularization after PCI. We have a very low threshold to perform a repeat cath and a repeat PCI. Whereas after you've gone through the big surgical procedure, it's unusual to for the patient. The patient feels that you failed if you have to have another procedure, and so it's very rare to refer that patient. We look for recurrent ischemia more after PCI compared to surgery. And the bottom line is, I think, shown beautifully in the syntax trial, that by the time you're referred for a repeat revascularization after surgery, your quality of life is much worse than compared to the change in quality of life for a repeat revascularization after PCI. So that's point number one. But point number two is almost all doctors and physicians feel that repeat revascularization is a much less important endpoint than death, large MI, and stroke. And frankly, I think it's less important than kidney failure and new atrial fibrillation requiring oral anticoagulation and major bleeds with transfusions, et cetera. So I do think death, MI, and stroke is the most appropriate endpoint, at least large MI. And to your answer about the PRECOMBAT trial, Dr. Park did show the data, and the death, MI, and stroke rates from PRECOMBAT were identical out to 10 years between the two therapies.
Thank you.
I have one question to the Dr. Stone. So the one of the limitations of PCI observed in the Excel trial, I think the higher rate of non-procedural spontaneous MI. So do you have any data of location of spontaneous MI in PCI group? If it occurred in the left main stenting, we have to focus more on the optimizing left main stenting. Then if it occurs more in the non-left main stenting or non-left main de novo lesion, so we have to improve treat the non-left main or improve the modality to detect the non-left main, non-left main stenosis. So do you have any data of location of MI in Excel trial?
So we're doing a detailed analysis of that, as well as complete versus incomplete revascularization, to try to find out where these future MIs came from. Suffice it to say, they're not from the left main. Very rarely did they come from the left main, either because of restenosis or stent thrombosis. It's almost always in other left main locations, either at the treated sites or at new sites. And we're working very hard to figure out the contribution of those progression of disease and non-stented lesions, the so-called vulnerable plaque progression that bypass grafts may have covered, to see the extent to which that explains the difference in late MIs. But many other studies have shown that late MIs are less after surgery compared to PCI. So for many years, I doubted this fact that the bypass grafts cover the untreated areas that might progress, but I'm starting to believe it more and more.
Okay, I think it's really, great session. So for the mini bifurcation PCI, I think it's time to close. And so really, thank you to joining us, and Gregg, Debbie, all the, discussion and moderator. Right. Thank you.
Thank
Thank
you.
you.
See you
Thank you.
later.
Bye-bye.
Thank you.
Thank you. Congratulations.
See you next time.